Thank you, everyone, for being so prompt about getting your lunches. We're ready to get started back up again. Our lunchtime speaker, it's a pleasure to introduce Dr. Sherry Gleed, Dean Sherry Gleed. Dr. Gleed and I probably, so our career tracks are in terms of, we've sort of known each other for many, many years, because I think I finished my PhD stint maybe 1 or 2 years after you did. And so we met when we were, sort of assistant professors in the profession, have just sort of kept track of each other over the years, but slightly different in terms of where we were. I was at the start of my career hanging out up in Canada. Dr. Gleed spent most of her career at Columbia University, and so while I was out in Canada, she took a break and went to work for the Council of Economic Advisors in Washington, D.C., and got to participate in the attempted Clinton healthcare reform plan at that time. And then went back to Columbia University. She's well known for her research in all sorts of work having to do with managed care organizations and also mental health, and she's written 2 terrific books on that particular topic. So she's very broad in terms of her interests. And then she also then went back to D.C. And has served as the Assistant Secretary for Planning Evaluation lately. So under Obamacare, and you're going to hear about that as well. And then New York University managed to recruit her to be their Dean of their School of Public Policy. So with that, I'm going to hand it over to Dr. Gleed.
So as I think about the introduction, actually, I 2 more things. I actually went to Washington the first time to work for the administration of George H.W. Bush, not for the Clintons. And I'm Canadian and Vivian is American, so the whole story is actually quite amusing if you put it all together. Anyway, I'm here to talk about the Affordable Care Act, which I worked on for a couple of years. And here's the basic outline of what I want to talk about. How it happened, why it was needed, some highlights, a little bit about implementation, effects, and a little bit about what's next. And I will talk really fast, because now I live in New York, so that we have some time for questions. But I'm actually going to start with a little bit of audience participation. One of the challenges about speaking at an anniversary event about the Affordable Care Act is that sometimes you look back on things and you don't really experience what it was like at the time. So I want to kind of pull you back a little bit and start my talk by talking about where the world was before the Affordable Care Act passed. And I want to start off by noting that although it might seem to some people that it was an inevitable thing that the United States would pass a universal health insurance plan, it was by no means inevitable. And the way I'm going to illustrate this to you is with these 4 quotations. Does somebody want to read them out for me? All right, I'll do it. Some people have said it would be a miracle if we passed healthcare reform, but I believe we live in a time of great change when miracles happen. Number 2, the cost of our healthcare has weighed down our economy and the conscience of our nation long enough, so let there be no doubt, healthcare reform cannot wait, it must not wait, and it will not wait another year. Number 3, I believe that comprehensive health insurance is an idea whose time has come. I believe that some kind of program will be enacted this year. Number 4, millions do not now have protection or security against the economic effects of sickness, and the time has now arrived for action to help them attain that opportunity and to help them get that protection. Now, these 4 quotations were spoken by 4 presidents of the United States. Can you tell me who they were? Well, who do you think said the first one? Well, actually, we'll make it easier. The last 4 presidents who advocated universal health insurance coverage, who were they? One's easy. Truman's one, Nixon, Clinton, and Obama, okay? So who said the first one? I'll take any guess. No audience has yet gotten it right, and at this point, even probability suggests somebody will. Well, it's one of those 4, Truman, Clinton, Nixon, or Obama? Nixon, okay. Number 2, who said that? Obama. Number 3. We already have Nixon. Okay? Number 4 is Clinton. All right, ready? You're wrong, but that's always the case. Nixon said number 3. Clinton said, he was the miracle guy. He said number 1. Truman said the last one, and Obama is the second one. So I think the thing that we kind of learned 2 things from this. One is, people have been thinking that this was around the corner for a long time, and it wasn't. And the second thing is there is gross inefficiency in Washington. They hire too many speechwriters. they could just recycle. So I say this to make the point that actually when Obama was elected in January of 2009 when he took office, the general feeling among most people who worked on healthcare reform was that it was not going to happen. And actually, there were many reasons to believe it was not going to happen, that universal health insurance was not going to happen. And the first and most important really was the political landscape at the time. Following the Clinton experience, there was a general sense among Democrats, among policy people more broadly, that in order to get health reform passed, you would have to have a filibuster-proof majority in the Senate, that was the way the game was going to be played one way or another. And if you look at the way that the politics came out, if you had been a veteran of the Clinton administration, as many people working on health reform at the time were, you can see that Obama actually picked up fewer electoral college votes than Clinton had, that actually Obama had fewer House Dems than Clinton had when he took office, and that actually in terms of Democrats in the Senate, it was pretty close. There were 56 Democrats in the Senate when Obama was elected, 41 Republicans, and 2 independents. So first things first, what's wrong with this picture? There's something wrong with the numbers I just gave you. You all know something about what those numbers should look like, and there's something wrong with them that's really obvious and doesn't require a great knowledge of the American political system. Even a Canadian can master it. How many senators are there? Right. What's the matter with my numbers? Leave the House I don't care about. It's the Senate I'm worried about. The Senate doesn't add up to 100. Do you see that? Okay, that's actually really important for healthcare reform, so hang on to that idea. Okay, so in January of 2009, there are 56 Democratic senators and there are 2 independents. And who are the 2 independents? Bernie Sanders and Joe Lieberman. Okay, so Bernie Sanders is a socialist on health insurance. He says so. On health insurance, he's going to vote with the Dems. And Joe Lieberman is who knows what, but he probably will vote with the Dems on health insurance, although you can't really be 100% sure. And there are 41 Republicans. That is not a filibuster-proof majority, so nobody thought anything was going to happen. The next thing that happened is that President Obama decided to put forward the stimulus plan. Do you remember that? The big stimulus plan? And as he put forward the stimulus plan, only 2 Republicans voted with him on the stimulus plan. And one of them was one of the senators from Maine. Maine doesn't really count. I can say that when I'm in Texas. So it was okay. But the other one was who? Does anyone know who the other Republican senator who voted for the stimulus plan was? See, you don't know the history of health reform. This is really critical. Arlen Specter, thank you very much. Arlen Specter from Pennsylvania. He voted for the stimulus plan, and he was immediately told that if he voted for the stimulus plan, he would face a Republican primary challenger, whereupon he said, well, if that's the story, I am going to become a Democrat. And the Dems had 57 Democrats and 2 independents, which makes 59. But we're still at 99, and the reason is that the Minnesota Senate race did not get decided until June 20th, when Al Franken was elected senator from Minnesota by a total margin of 312 votes. So all of health reform really depended on actually half of that number in Minnesota. And that was kind of the first big dramatic moment that made it possible for anyone to imagine that health reform was going to go forward. And that happened on June 20th. And that filibuster-proof majority lasted for exactly 213 days. That was the window in which it was politically feasible to imagine health reform happening, because after 213 days, what happened next? Scott Brown got elected in Massachusetts, and everyone thought health reform was dead. Most people working on it thought health reform was dead, except Nancy Pelosi and President Obama and everybody made a deal, and the phoenix of health reform rose from the ashes. So you'd think everything was all good and fine after all of that, but that was not the end. The states and the National Federation of Independent Business sued to make the individual mandate, to argue that the individual mandate was not constitutional, and there was a lot of belief that the Supreme Court was going to say it wasn't constitutional, but finally, June 28, 2012, I was on the top of one of the mountains in the Alps. The Supreme Court decided that NFIB, that the individual mandate was constitutional under the taxing clause and made the Medicaid expansion, we can use the word voluntary. So the phoenix of health reform rose from the ashes again. But it wasn't over, because that November there was an election, and a big issue in that election was health reform. November 6, 2012, presidential and congressional elections. President Obama hangs on, and the phoenix of health reform rises from the ashes again. But it wasn't over. Okay? So October 1st, 2013, the health exchanges are supposed to open, and they didn't. And the phoenix of health reform rose from the ashes again, and we thought it was over, but it wasn't, because then there was King versus Burwell about the subsidies, right? And that wasn't actually decided until June 25th, 2015, and the phoenix of health reform rose from the ashes one more time. Now, why do I give you this whole story? This thing is the most knife-edge, unlikely, tight-ropey thing that you can imagine. This had so many near-death experiences that it could have been an ER nurse. So it's really important as you think back on it and as you think of the various problems it's had, which are legion, many different kinds of problems, to remember that it's not like the way that they teach it to you in civics class. The way things actually happen in the real world is a lot messier than that. So very exciting for everybody who was concerned about healthcare reform. President Obama signing it, really, really big deal. Okay, so now let's go back a little further and talk just a second about why it was important, why it happened. I'm going to give you just two little different perspectives on this, not politics, for a moment. And the first thing I want to say is, why didn't healthcare reform happen in the US earlier? So, if you look at all the other developed countries, they had universal health insurance for many, many years. We didn't have it. Why not? Well, one reason is if you looked at the status of the private insurance market in the United States between 1945 and even if I took this data forward a little bit, maybe even to 1990, it was growing by leaps and bounds. More and more people were picking up private insurance. Aside from the elderly, and we could talk about that later, you really had this sense that if you just left things alone, the market was going to take care of things. And so there was a very credible argument against moving forward with coverage, because you could make the argument that private markets could do it. But that story basically ends around 1999. From 1999 on, the number of people, the number of human beings enrolled in private insurance drops and flattens out and doesn't come back. And this is despite new tax breaks and other things that we're doing that are happening in the Bush administration. It's just not coming back. And the consequence of that total flattening out of private insurance is that the percentage of the population with private insurance drops nearly 10 points over the 2000s. So the private insurance market, which had been a pretty robust thing, looked like it was really taking care of the problem of coverage, has really started to fall apart. And I think that actually galvanized a lot of attention on trying to do something about it. Okay, so that's argument one. Why was the private insurance market falling apart? The answer is pretty simple. Healthcare was getting really expensive compared to people's incomes. I'm going to show you this chart. It's kind of weird. Just be patient. All right? I'm going to compare 1976 and 2006 because that's the data I've got. And I'm going to show you, first of all, monthly household income. So this is monthly and it's household, right? And what you see here is the story you've heard many times. The median household income in the US is not moving very much over this period. These are inflation-adjusted numbers. People are doing about the same in 2006 as in 76. Now, the other slide I'm going to show you is per capita annual health spending. Doesn't make sense to put them on the same graph, but instead of changing the axes, I'm just going to change the metrics. And here's what happens to that. So in 1976, healthcare spending relative to people's incomes is relatively low. By 2006, it's really high. The average person can't really anticipate that they're going to be able to pay their health expenses if they don't have health insurance. It's a real change in the world. Now, is that a bad thing? Well, I'm really happy that I went after David's talk, because here's the flip side of that. Life expectancy at age 40. I'm going to show you male and female life expectancy at age 40. Why age 40? Because by age 40, you've done all the dumb things you're going to do. So if we're going to look at life expectancy earlier than that, there's a lot of things that people do that are really bad for them. By age 40, I mean, you know. So what you see over this period is that life expectancy at age 40 has really improved a lot. Okay? So I can ask you guys a simple question, a lot like David's question. If I offered you the chance to live for 4.8 extra years by spending $4,000 extra a year, or for you women, 2.7 extra years, would you take the deal? Would anybody not take the deal? Everybody would take the deal. Everyone would always take the deal, right? This is an excellent deal, right? $4,000 a year, $4,000 extra a year, but you get to live 5 more years. That's pretty good, right? Okay, so even, any cost effectiveness measure, it's gonna be okay. So this looks good. So actually, there were many of the people we just talked about, Michael Chernow and David Cutler and all those people, there was a little cottage industry doing this illness by illness during the 1990s. And we always came to the conclusion that healthcare is really expensive, but it's worth it. And that actually, if you're a health economist, it makes you really nervous. You don't want to touch the healthcare system. You don't want to kill the goose that's laying the golden egg. But I'm going to show you some slides that I actually find deeply, deeply troubling. So here they go. So this is the same axes as I had before, male life expectancy at 40 and per capita health spending, inflation adjusted. And now I've put some other countries on the slide. I picked some high income countries, basically every high income country I could find data on. And the thing I want to tell you about these countries, can you read what they are? Germany, Australia, New Zealand, France, Canada, the Netherlands, Japan, Sweden, Switzerland. These countries run dramatically different healthcare systems from one another. The healthcare systems of Switzerland and Sweden are completely different. One of them has for-profit private health insurance. The other one has a national health service. These are all very, very different healthcare systems. We are often thinking about everybody being different from the United States. The only dimension in which they are all similar to one another is that they have universal health insurance and we didn't in 1976. Okay, so these are very, very different countries in terms of their health systems. They're also very, very different countries in terms of the diversity of their populations, health habits. So Germany's in here as well as Japan, the bratwurst as well as the sushi. You have the smokers in there and the less smoking people. You have places with a lot of immigration. There's a large diversity of countries in there. Okay, so that's 1976. And you can see that the interesting thing here is that the US is really in the middle of the pack. We're not the most expensive country, we're not the longest lived country, we're not the shortest lived country, we're in the middle of the pack. There is 1986, here is 1996. So this is at the end of the Clinton health reform, which didn't happen. You can see all these other countries there, and here we are, everybody's getting somewhat more expensive. So I showed you that picture before, and I said, look, we're spending more, but we're getting more, right? Okay. This is 2006. All right? Here's where we started. We're spending more and we're getting more, but other countries are spending less more and getting more. This is very troubling, but what it says to me is, it's not that dangerous to go ahead with healthcare reform. There are lots of ways to do this that are not necessarily going to kill the golden egg. Because look at all these other countries which seem to be advancing in life expectancy more rapidly than we are and spending a lot less money doing it. And I think actually one of the really intriguing things is how similar all those other countries now look to one another in terms of their spending and life expectancy and what an outlier we are. It's very interesting. Anyway, okay, so that's the run-up to why you might want to do health reform. Now, what is it? This, ladies and gentlemen, is a picture of a camel. Why am I showing you a picture of a camel? As you know, a camel is a horse that was designed by a committee. Right? That's what a camel is. Have you heard that expression before? A camel is a horse that is designed by a committee. Well, let's look at the Affordable Care Act. There were 2 Senate committees that wrote the Senate bill. There were 3 House committees that wrote the House bill. There was no reconciliation or conference because of Scott Brown being elected and all the machinations. After they passed the thing, they passed the whole thing, and then the Supreme Court decides to paint stripes on it, right, by making the Medicaid expansion voluntary. So this is not just one committee. If you think a camel is a horse designed by a committee, this is the Affordable Care Act. Okay? I wanted to find a friendly chimera, but I couldn't find a friendly chimera, but it's got the wings of one thing and the feet of something else. It is not a coherent document, and you cannot explain it in an elevator. You cannot explain it in even a long elevator ride. So this is a very, very complicated piece of legislation. I want to talk through some pieces of it, and I particularly want to focus on things that I can tell you that other people can't tell you based on my own experience. And some of this is I haven't really tried out before, so bear with me. So the first piece of the legislation, and the piece that everybody loves, almost everybody loves, is reforming insurer practice. So there's a bunch of provisions in the law, and even Republicans want to hold on to them, that make health insurance in the non-group market look better, getting rid of pre-existing conditions and underwriting stuff and medical loss ratios. And I've flagged one of them here, annual limits, because it's something that we did in HHS where we had to write the regulations, and it taught me a lot about regulation and about how things work and about the things that you expect and the things you don't expect. And the number one lesson of working in Washington, which is when you pick up a rock, you find creepy crawlies underneath it. So annual limits. Some of the people in this room are economists, and you know that health insurance is designed, or all insurance is designed to protect you against catastrophic expenses. So if coverage is designed to protect you against catastrophic expenses, it's a real question about why health plans have annual limits in them. Why do health plans have annual limits in them? Especially because it turns out that annual limits do not save very much money for health plans. Very few people actually in the employer market ever hit those $1 million annual limits. And if you actually look at how much of a premium change would be caused across the market by getting rid of annual limits, it is very, very small. So it's a significant amount of risk protection that people would be getting, but because that's the stuff you really care about, and you're not really, there's no moral hazard over $100,000. Well, there is moral hazard, but we're not going to do anything about it. So this is not a moral hazard issue. This is just a, well, what's going on here issue. My explanation for this is that this is probably the classic case of racing to the bottom in the insurance market. Once somebody's got an annual limit, you don't want to be the sucker that's got a plan without an annual limit. Because anybody who knows that they've got a kid with a health condition or something is going to join your health plan. So you don't want to be the last employer on the block without an annual limit. And my guess is that that's why this is going on, because even really Luke's health plans that you wouldn't think would have it had annual limits, and they were pretty high, around $2 million. So this idea was very popular because it seems like such an evil thing to do to people, to cut off their health insurance once they've spent some amount of money, right? Seems like a no-brainer. It's not going to raise prices very much. So that was the first thing that was supposed to go into effect in the Obama health plan. There you go. And this is the way the rule is going to go into effect. In 2010, I went backwards. You're going to get my whole story before I go. Quick, you didn't read that. In 2010, the annual limits would have to be $750,000. It would ratchet up to $2 million, and they wouldn't be permitted at all after 2014. At the time that we did this, the Kaiser Foundation does a survey of employer plans. We'd done some, not the Obama administration, but all the economists had done work on employer plans and stuff. The average annual limits were way up in the $2 million range. So we were not expecting that this would be a terribly ugly scenario, that we're going to phase this thing in and we're going to get rid of the annual limits. And what happened? It turned out that there was a trickle, a stream of fast food restaurant executives coming into the White House saying, if you get rid of the annual limits, we're going to be in really big trouble. Because we do offer health insurance to our workers, but this is what the health insurance looks like. At McDonald's, you could buy a plan. It costs $56 a month, so $720 a year, and it paid up to $2,000 in benefits a year. $2,000, a lot of you are in the healthcare system, that does not pay for one night in the hospital, right? Not if they're actually going to do anything to you, right? So this plan has incredibly high administrative cost, it's very, very high loading, and it's got really cruddy benefits. There are reasons people might still want this plan, but it's not the plans that we thought were out there. Actually, I went back because I wondered how could we have been so stupid to try and find out whether anybody had been writing about these plans. But actually, everyone was excited about health savings accounts. And we were all worried about high deductible plans, and no one really was paying attention to these limited benefit plans that were out there in the market. It turned out that there were 3 million people who reported each year on annual surveys that they had health insurance, but this is what they had. So the first thing the secretary had to do was say, you know what, you can keep those plans until 2014. Because otherwise, the first thing that would happen immediately after the passage of health reform is that 3 million people would lose their health insurance coverage. Now, you might argue that they didn't have health insurance coverage in any meaningful sense before that, but I don't think that's how the newspapers would have read it. So this problem of kind of not having the full information and really not having a good sense of what that market looked like and not really anticipating that these plans were out there turned out to be a big problem. And that was not the end of it, because that same kind of problem resurfaced in implementation. So when we were preparing for implementation, one of the things that we were really, really worried about was a phenomenon that was to be called rate shock. Rate shock was all over the newspapers, and everyone was very worried about it. Indeed, this is from the House Energy and Commerce Committee, an analysis done in March 2013 about how much health insurance premiums were going to skyrocket once health insurance coverage expansion took place in January 2014. The number was in the order of 80–90%, and we within the administration were really, really worried about this. This is going to be catastrophic. People are going to see 80 or 90% premium increases, and that's going to be really upsetting. It didn't happen. Right? This just didn't happen. Do you remember the story? People seeing 80% rate increases. Did you actually see the 80% increases? No. What happened? The insurance companies realized that putting out 80 or 90% increases was going to be politically really, really difficult for them. They were going to look really bad. So they decided to do something quite different, which we had not expected at all. They said, we're going to cancel the policies. We're just not going to renew the policies. And you remember that. That was the PolitiFact lie of the year, right? If you want to keep your health plan, you'll be able to keep your health plan, right? And in fact, you couldn't keep your health plan because all these policies were canceled. The policy cancellations were just the rate shock that we had not seen. It was just the flip side of rate shock. Instead of rate shock happening, policy cancellations happened. And it was basically the same phenomenon as those limited benefit plans. Most of this policy cancellation was stuff that had provisions in it that probably would not have passed muster under the new insurance regulations. So lots of policy cancellations, in part because the market is, in some ways, when you lift the rock, a lot messier than you anticipate. So there's a lot of messiness under the market. I think the important thing to realize here is it's not clear that even those cancellations really left most of the people who were canceled wound up in a much better place. Some people didn't, but most people did because those plans were really pretty awful. But at the time, it was pretty devastating. So that's number one. Okay, number two, another piece of the plan that got a lot of positive feedback was improvements in the quality of coverage. So preventive services in Medicare would be covered without cost sharing. The Part D donut hole in Medicare will be filled. And then this idea of essential health benefits, which actually my office worked on. So if we get to the questions part, you can ask me questions about it. But essential health benefits and standardized cost sharing. And the one that I've highlighted in red here is preventive services with no copay, which actually everybody loves. Does everybody in this room like the idea that preventive services should have no copay? Oh, I got Paul here, but basically, you know, this is like everybody loved it. The Republicans in Congress loved it. The Democrats in Congress loved it. Everybody loved it. It had been floating around for a long time. Preventive services should come with no copay. So this is my second lesson from Washington. You really have to remember that politics is like a Cracker Jacks bag. Every Cracker Jacks bag has a prize in it. So let me talk about preventive services with no copay for just a minute to give you a sense of what this is about. So preventive services with no copay sounds really good, but the first thing you have to do if you want to say preventive services with no copay is to define what you mean by preventive services. Well, it turns out that in the wisdom of the federal government, there is a task force called the United States Preventive Services Task Force, and their job is to figure out which preventive services really work so that their people get them. And they grade the preventive services A, B, C, D, E, maybe F, I don't know. And so when they decided to do this thing, they said, it's really easy. We're just going to say any preventive service that the United States Preventive Services Task Force, in its wisdom, grades A or B, is available without copay. Okay? Everybody think that's okay? Anybody I'm sure there are people from Texas on the U.S. Preventive Services Task Force. I'm quite sure of that, all right? Now, the thing that's wonderful about the United States Preventive Services Task Force is it's a bunch of professors and doctors, and they have about zero political savvy. So in the fall of 2009, as the Congress is debating healthcare reform, as the Tea Party is rising, and people are really upset about all kinds of things, the United States Preventive Services Task Force decides this is the moment to release a new recommendation. Not just about anything. What did they decide to release? Mammograms. Mammograms. You don't need mammograms as often as you thought. Okay. If you're going to do something really controversial, make it be about women's bodies, because that could really engage Congress for a long time. And it did. They got really excited. If they had done, PSA testing, I think it would have been much less of an issue. Thank you. So USPSTF comes out and says, and Congress immediately buzzes to attention and says, whatever goes in this health reform bill, which we don't even want to have pass, but if it should pass, those women are going to get their mammograms. Okay? So there were amendments to health reform proposed by both Republicans and Democrats saying, just make sure that women get their mammograms. And in the end, the Mikulski Amendment won. And Mikulski said, what we learned from this is that the United States Preventive Services Task Force does not understand women. That's what she said. So we need a new task force that will understand women. And the first job I had when I got to Washington was to convene that task force. So like Congress told me, we went to the IOM and said, can you please come up with a task force to figure out what preventive services women need? And they came back. They did. We had this IOM committee, and they came back, and they brought me the things that they recommend, including things like breast pumps. And I was like, breast pumps, really? But we said, okay, we're just going to do whatever they say, because we don't want to touch this. It's a political nightmare. What did the United States Preventive Services, not the Women's Task Force, say? What preventive service should be offered without cost sharing? Do you remember what they said? Contraceptives. Contraceptives are not in the Affordable Care Act. They're not in the legislation at all. They're not in the U.S. Preventive Services Task Force. They were the the prize in the Cracker Jack box that we got because, of course, as soon as they announced that contraceptive coverage had to be available without copay, all heck broke loose, right? And you will remember this picture, which every Democratic operative has in their wallet. This is the House hearing on contraceptive coverage. I kid you not, I could not make this up. And that brought us Hobby Lobby and all the exciting stuff. Now, when people talk about this thing, they get it all wrong, and they think that what this is about is that the health reform law mandates contraceptive coverage. That's actually not how it worked. In fact, if the health reform law had mandated contraceptive coverage, this whole thing wouldn't have happened because the way the health reform law mandates coverage, it's only in the non-group market. It would have been a completely different story. Instead, what they mandated is that it was a preventive service that had to be covered with no cost sharing. Okay? Now, it turns out almost all health plans already covered contraception. So Hobby Lobby, for all that it's very exciting, actually affects almost nobody. Over 95% of plans covered contraception before the ACA passed. It's very cost effective. Babies cost a lot more than contraception. And in fact, this provision of the ACA had exactly the effect it was intended to have, which is cost sharing for contraception fell. That was what it was supposed to do, and that actually apparently happened. But it's really interesting because it wasn't in anybody's mind that the whole thing was going to explode in this particular way, because you never know what prize you find in the Cracker Jacks box. Okay, what else? Cost containment. I'm going to come back to this top line number in a minute, but when the law was being designed, the first thing that really everybody coalesced around was how much the coverage expansions could cost. Which is a funny way to do legislation, but actually that top line number of $788 billion was kind of figured out before anything else. And you'll see what that means afterwards. So they decided to find money in the health system essentially to pay that $788 billion, and it's reductions in payment to Medicare Advantage plans, reductions in Medicare payments to hospitals, and the excise tax on high-cost plans that starts in 2018. So this is really where the bulk of the money that pays for the coverage expansions was coming from. I'm not actually going to talk any more about that for now. Then there are delivery system reforms, which I'm sure you've heard about a million times, so I'm not going to talk about those. Instead, I want to talk a little bit about the expansions of coverage, and again, I want to give you some perspectives on what happened and the implementation of it, and how essentially policy design and implementation, as you can sort of see from this whole story, really fit together in a way that is unanticipatable, I don't know if this is a word, and really quite interesting. So the big piece of the coverage expansions that was kind of novel are the tax credits up to 400% of the federal poverty line. That's what's going to get people to buy insurance in the exchanges, as well as the Medicaid expansions. And I've been thinking about this a lot, maybe because my school now has an urban design program. I like to think of this and we're in Houston, so there's no zoning, so you don't even know what I'm talking about. But in places that have zoning, there is an idea around a building called an envelope. The envelope of the building is the size of the building you can build that is consistent with the zoning code. All right? So it's like an outline of a building, and then you, as the architect, can design whatever building fits within that envelope. So I want you to think about the Affordable Care expansions in the same way. The building is really the $788 billion. You have $708 billion, whatever, in 10-year cost. And you can do whatever you want as long as you don't spend more than $788 billion, but your goal is to cover as many people as possible. Okay, so this is the design as a policy analysis task. It's like you have a budget constraint and you have a utility function you're trying to optimize. How many people can we cover? And we got to get to $788 billion. So what does this give you? It gives you an incredibly complicated subsidy structure. So here's how the subsidy structure works. If your income is less than 100% and you don't live in Texas, you go on Medicaid. If your income is between 100 and 133%, you can either get Medicaid or go into the exchanges. If your income is between 133 and 400%, if you purchase the second lowest cost silver plan, then your payments are, and here's the long schedule. If you buy a different plan, your payments are different. So that's the basic structure of the subsidies. Now on top of that, not everybody's eligible for the subsidies. There are lots and lots of restrictions on who gets the subsidies. You can't be a dependent. You can't be illegal. You can't have offers of other public coverage. Your employer can't offer you coverage. If you're disabled, we need to know about that too. There's a lot of things that we want to do. And why do we want to do that? Because we want to make sure that every dollar of that $788 billion is going to have its maximum effect on increasing coverage. We don't want any of those dollars to leak to people who might have coverage even without the law, because there's only $788 billion and you want to try and maximize coverage. Does everybody see that? So in order to figure out how much, what your premiums are and how much you're going to get coverage, we need to know your income, whether you're eligible for this program, whether you're eligible for other insurance, what the second lowest cost silver plan in your area is, what the premiums for you or your family for all other plans in your rating area are. And these are all the things that I need to know before I can quote you a price for health insurance across the different choices that you have in your area. It's pretty crazy. So this gives you an incredibly complicated eligibility form that asks a lot of questions. Even though people put a lot of effort to try and make it as simple as possible, it's got to ask a lot of questions because it's got to make sure that it's using every dollar for this purpose. If you were willing to just cover everyone, like in Medicare, if you were just willing to do what Medicare did and say everyone 65 and over is covered, you wouldn't need a very complicated form because you're basically willing to take the fact that there are a lot of people with private insurance who are going to switch to Medicare. Medicare caused a lot of crowd out, the way we economists call it. This plan is designed to have as little crowd out as possible, and that means that it's got a lot of administrative complexity associated with it. Okay, where does that show up? Now you got to make the thing work. And you remember what happened, right? The system is down at this moment. And there's the president looking really, really unhappy. Now, what happened? Again, I think this is something people, it's a complicated story, so I want to just give you a little flavor of it. This is the way that the health reform marketplace's web structure was supposed to work. There is a thing in the middle called the hub, which is the federal hub. The federal hub queries the INS about people's immigration status. It queries the IRS about people's taxable income, because that's what is used to determine their eligibility for subsidies. And it's sort of the core centerpiece of the whole thing. States operate marketplaces like New York, California, Connecticut, Massachusetts. They operate their own marketplaces that query the hub about people they want to enroll. And the federal government operates marketplaces in a lot of other places that also query the hub about people that they want to enroll. Everybody was very worried about the functioning of the hub because it's incredibly kludgy to try and get into the INS and IRS databases. And people worked very hard on the hub, but people were more sanguine about how the marketplaces were going to work, because everyone said it's like Travelocity, right? Remember, everyone said it's like Travelocity? Except imagine if Travelocity had a 6-page eligibility format. And it turned out that there were loads of people who didn't fit in any of the categories anyone had thought of. If we have time afterwards, I'll give you some interesting stories about them. So there are really complicated lives, and they don't fit on that eligibility form. They crash the system, all right? So everyone thought that that part was going to be fine, and it was the hub that was going to be a worry. But as you all know, that's not what happened. The hub worked fine. We know that because the exchanges in California and New York and Connecticut all worked fine, and they wouldn't have worked fine if the hub wasn't working. But the Travelocity piece of this crashed. It crashed at the federal level, and it crashed in a lot of states really badly. So if we just look at data on what happened, you can see this is the beginning of health reform rollout. This is the really bad times in October. Nobody is enrolling except in a couple of states, which tells us that the hub was working. Because if the hub had not been working, no one could have enrolled. And then actually over time, the federal exchanges caught up with the state exchange, with a couple of states that never actually got their things to work. really badly functioning states like Oregon and Massachusetts and Hawaii, states that we think of as being dysfunctional, maybe not so much, but they couldn't get their marketplaces to work. And over time, actually, the federal marketplace did just about as well as the state marketplaces on average. And by the second year, there was really no issue there. Now, two questions. One is, why was it such a disaster? And I think the reason is because we had basically legislated it to be a disaster by making it so incredibly complicated. And then the second question is, did it matter? And the interesting thing is, it probably didn't matter. By April, the number of people enrolled really did not differentiate among the federal and the state exchanges. And the reason for that, which is kind of funny, is that everybody thought people would just go on the web and buy their insurance like Travelocity, but it's really, really hard to buy health insurance. And most people found out that they couldn't really do it on their own. So actually, the web interface didn't matter as much because it's actually so hard to do it that people wound up going to agents and brokers and other ways of doing it, and it didn't work the way people had anticipated. Okay, so what happened in the end? The coverage effects. So this is the slide that makes people in Washington happy, some people in Washington happy. This is the change in health insurance coverage over time. Pretty dramatic declines in uninsurance. I mean, those are pretty startling. And actually, if you look at other data, these are the lowest uninsurance rates in recorded history, which doesn't mean the lowest uninsurance rates ever. It just means that since we started collecting data that we can compare over time. And I like to compare it to other countries. This is the number of people who are newly insured under the ACA as of March. It's actually much more than the entire population of Switzerland, about almost the full population of the Netherlands. These are countries with individual mandates that we had thought about as we did this, and about a third of the population of Canada, more than a third of the population of Canada. So lots of people have actually gained coverage through the law. So what's next? One big question is what's going to happen to the Medicaid expansions. I will take questions on this if you ask me questions later. My general view of it is that if the Democrats take either any of the presidency, the House, or the Senate in 2016, most of the remaining states will begin to participate in the Medicaid expansion. So if it seems as though this law is not going anywhere, I would anticipate, using my expert political judgment, I am an economist, that there will be much more sign up into the Medicaid expansions. Another question is what's going to happen to the marketplaces. This year, the premium increases are quite high relative to past experience, but I think it's important to realize that last year they were pretty low. On average, I don't think that there's much evidence that the marketplaces are not really working. Lessons. So just very, very few. And I think one of the really interesting things is how did the ACA happen in that, unlike the presidents who I had up at the very beginning, so President Nixon was really committed to healthcare reform. We don't remember that, but he had younger brothers who had died of tuberculosis. His mother ran tuberculosis home out of his house, and he was very, very committed to healthcare reform, and he lost. He wasn't able to get it passed. But these three people, Obama, Harry Reid, and Nancy Pelosi, actually were not terribly interested in healthcare reform. None of them had been actively working on it. It was not on their own personal agendas. And in some ways, that made it much easier, because they were not so concerned about getting a particular plan passed. They just wanted to get something passed. And it's a very different thing to be going after a particular objective and just to say, look, what we want is to get close to universal health insurance, and that's what we're going to push for. So I think one thing that's really interesting here is, yeah, it's really important to have a champion on your particular topic, but sometimes you really want a champion whose goal is just to get something out. And so that was an interesting aspect of this. The second really interesting aspect of it, from my own personal perspective, is another person. I'm going to put up a face here. Tell me if you recognize this face. How many people know who this person is? Lee Moore. Anyone else? David? Anyone else? All right, this is a man named Douglas Elmendorf. He is now the dean of the Kennedy School. He just took over as my counterpart at the Kennedy School. And during the time that health reform happened, he was the director of the Congressional Budget Office, which is the office that has to do something called score all health reform proposals. That is, he has to figure out how much they're going to cost and how many people they're going to cover. He had 213 days to do this because that was really the time when live health reform proposals were being put forward to him. And it is not an easy thing to do. Actually, it's a really hard thing to figure out how many people will be covered and what will happen under every possible arrangement that the Congress, in its delirium, might dream up from time to time. The astonishing thing is how well the CBO did it. They were actually remarkably accurate in their predictions, and they did it in real time, remarkably fast, in 213 days. How did they do that? Well, now I get to be a little bit self-serving. The reason they were able to do it is because really for the past 20 years, since the end of the Clinton reform at least, an enormous amount of effort has gone into estimating the parameters that go into the models that allow you to forecast how many people will get covered under different configurations and how much it will cost. Those models had been really carefully developed and tested over a long period of time so that by the time health reform happened, it was actually possible to make these estimates in real time. If it had not been possible, and it wasn't in the Clinton administration, it would have been much, much more difficult to get this thing done and to make the tweaks that allowed them to do it. So the future, this Chinese fortune cookie, may you live in interesting times. The nice thing about working in healthcare is you always will. I actually think I used to end my slides before health reform passed with a picture of Otto von Bismarck and a picture of Angela Merkel. What do those two people have in common? They are both chancellors of Germany. Why is Bismarck important? First health insurance plan, first nearly universal health insurance plan. So why did I put them both up? Bismarck brought in universal health insurance, nearly universal health insurance in Germany in the 1880s, and Angela Merkel is still fixing it. All right? This is not a one-time thing. Whether you like this law or you don't like this law, and believe me, there are plenty of things in it to like and to hate. It's not over, and it couldn't be over because actually of David's talk, technology in the healthcare sector moves so fast that even if you have a plan that works in 1 minute, it's going to change in a few minutes later. Now, my own sense is that this is not the moment for radical change. We have to figure out, I always think of, have you ever read the book, The Little Prince? The picture of the python digesting the elephant? I think of the U.S. healthcare system digesting the Affordable Care Act in that way, right? This thing is still moving through the system, and I don't really know what is going to turn out to work and not work. So I sort of feel like maybe a little bit of not radical change at this moment would be very good for people, but there will be change. And in order for that change to work well, I think that we also, as researchers and scholars, need to think about how to move forward. We need data. We need data that will allow us to lift those stones up and find out what's underneath them. We need ideas and analysis to show how you can implement things in a political context. What can you actually do? It's all very well to design beautiful plans in the comfort of your living room, but what could actually pass when you're at best likely to have 60 votes in the Senate, not 61. So you can't let somebody go. You can't say this plan is not satisfactory to person X, but that's okay. You need to hold every single one of them. You need research studies that the Congressional Budget Office and other people who are making forecasts can rely on. And also, you really need exceptional managers because the healthcare system has become so complicated and so sophisticated on every aspect of it that we really need great people, not only delivering services, but also running the ACOs, running the exchanges, doing all of this great work. So I'm delighted to see so many people here engaged in that activity. And let me stop there and I'll take questions. Thank you. I do talk like a New Yorker, sorry. Questions? Which stories would you like? There are so many, I could be here till tomorrow. What story would you like? Vivian? All right. Yeah, let's have a, okay.
Yeah, we hold off on the stories for a bit, although I'm sure I'll like those. The one thing that I keep finding myself saying now that I would like the Affordable Care Act to have included is price transparency. And was that ever up for discussion, or what do you think about it?
So, I guess I would say two things about it. One is price transparency is a big move. It's not a small move. I mean, there are levels of price transparency that are a small move, but the ones that probably matter are a big move. From my own perspective on this, I think we don't know enough about how it would work or what it would mean for the federal government to embark on it on a large scale. There are price transparency elements of the Affordable Care Act, for example, or there are transparency elements more generally. There are sunshine provisions that, for example, doctors to report about pharmaceutical company stuff. There were actually new initiatives by Medicare, you will remember, to put out, and you've seen it because there's been a lot of controversy about it, to put out Medicare billings, right? But if you think about, one thing to think about in price transparency, actually here's an interesting story that kind of meshes with it. So one of the things as a health services researcher, as a policy implementer, I was really interested in is when you set up these marketplaces, right, one of the things that the marketplaces are going to have to do is something called risk adjustment. They have to figure out whether the people who enroll in health insurance plan 1 are healthier or sicker than the people who are going to enroll in health insurance plan 2. Okay. So the natural way to imagine doing risk adjustment is the way that Medicare does risk adjustment, which is that the insurance companies report all of their diagnoses to Medicare, and Medicare does the risk adjustment. We were told, and I don't remember who said it, that under no circumstances could the marketplaces collect information about the individuals enrolled in the exchanges. All right? That would just be a breach. It would give off the sense that the federal government, in some sense, had data on the health conditions of every American. Of course, they have data on the health conditions of every American over 65, but that's a different story. We didn't want to, it would only have been the people in the exchanges, but it doesn't matter. From a political perspective, politics is politics. We could not collect that data. Now, you can imagine how many millions of things you would have liked to do with that data if you could just collect it. So instead, we actually developed a system of risk adjustment, which I call the knife sharpener model. I don't know if you had this when you were a kid, but there used to be a guy in a van that drove through the streets sharpening knives. Do you remember that? And he rang a bell, and everyone would bring their knives out to be sharpened. That's how we do risk adjustment in the exchanges. That is, there is an algorithm that the insurance companies impose themselves, and we never see, the federal government never sees the data, except for auditing and stuff like that, but not in a general way. So there was an enormous resistance to the federal government collecting a lot of individual level data. If you don't want the federal government to collect individual data, you have to figure out how you're going to make price transparency work. So there was money for all payer data sets. There were efforts to build those, for the states to build them, not the federal government, but to push out money to the states to do some price transparency stuff. But there wasn't going to be price transparency for political reasons. But the second reason not to do price transparency is we haven't done the research. It sounds like a great idea. We actually don't have, to be honest, if you think about the marketplaces that we normally shop in, we don't have the kind of price transparency we want in healthcare in any of those marketplaces. You have no idea how much Starbucks pays for coffee. You know how much you pay for the final product, but you don't know how much the inputs cost. If you think about the doctor's prices and the hospital prices as being inputs into the insurance premium, we're actually barking up a tree we don't normally touch. So that's a terrible metaphor. But you understand where you see what where I'm saying. So as a policymaker, I would be much more comfortable doing experiments on price transparency and seeing what happens before the federal government really imposes this in a big way. And that's also, the states are laboratories of democracy. We had Massachusetts health insurance reform. To be totally honest, and I don't want to disagree with the next person who's going to speak, Paul, if Romney had not done health insurance reform in Massachusetts, the Affordable Care Act would not have passed. There was no way it could have happened. So, yes.
Oh, I was wondering your thoughts on, some of the repeal of the ACA has been kind of piecemeal. What your thoughts are on sort of the, not reconciliation, because we know that that's a surefire veto, but the idea of doing them piecemeal versus doing a package, especially, the Cadillac tax, medical device tax repeal. So those are, so if you're going to talk about putting it in little pieces, you have to talk about each individual piece, because they are all different. Do you know what I mean? Like medical device tax and Cadillac tax, if they were packaged, I don't think they would happen. Conceivably, maybe one or the other of them might happen. So do you see what I'm saying? So if the overall global repeal is not going to happen as long as there's a Democratic president. That's just not going to happen unless you have enough senators to override a veto. But even then, I think we are in a very, very different place now than we were in 2009. There are some number of people, let's say 12 million people, who have names and pictures, and we know who they are, who will lose health insurance if this thing is repealed.
And and 12 million is a big number. When you work in Washington, you get scared of big numbers, because in 12 million people, there is a little girl with cancer, and she's pretty. Right? Whereas before you passed this thing, that little girl didn't exist. You didn't know who she was, and so it didn't matter. So repealing the whole thing is a very different game than not passing it in the first place, or having the Supreme Court repeal it for you. Actually having to vote on that little girl is going to be really not easy. So let's take the piecemeal approach. The challenge with the piecemeal approach is, well, I'll talk about the medical devices in a minute. You need to find the money. So first of all, it's hard for Congress to find money, and they're going to have to find money, because to repeal it without finding money, I think, is very hard to do. On the Cadillac tax, the challenge is that enough Republicans have come out in favor of it, or some variant of it, that it's going to be hard to build that coalition. On the medical device tax, it's not a big amount of money. It's more the principle of the thing, and more the fact that a lot of people don't. Some people love medical device manufacturers on the Hill, and some people really hate them. So I don't know how the politics of that works out. But it's not important. So even if it got repealed, it's a teeny amount of money, and it would be symbolic. So then it kind of gets into the symbolic politics world. It's like the House voting repeal. So does Obama veto it because he doesn't want symbolically to make it look like anything's gone? But those are not the changes that matter. I mean, the Cadillac tax is conceivably a change that would really matter, but from conversations I've had with other people, my guess is it's not going anywhere. It's going to stay. But I could be wrong. I haven't got a good prediction on this one. The things that really matter are, are we going to change the subsidy structure? Are we going to change the way that the marketplaces work? Are we going to fold Medicaid in a different way? The big parameters, the little stuff, it's not that important. Yes.
Hi. Was there ever a moment that politicians were actually considering universal healthcare, a single-payer system, and why or why not? And I'm not interested. I'm an anthropologist, so I kind of understand the social and emotional aspect of it. But
so I mean, in 1955, they were thinking about it.
No, I mean during the ACA.
Well,
discussions.
so the ACA didn't come out of a bubble. Because of the way the Obama administration decided to do it after the failure of the Clinton reform, it really most of the design of the plan came out of the Senate Finance Committee. And the Senate Finance Committee had been holding hearings on healthcare reform for 3 years, perhaps, at least 2 years, prior to Obama being elected. So both the Republicans and the Democrats on that committee had spoken about it, and there was a strong sense of what the dimensions of a plan would be. There was also a pretty strong sense of where the votes would be. So when you actually look into the minutia of what was actually on the table in the debate, it's a very, very narrow, the debate happened within a very, very narrow range, which is pretty typical of this kind of thing, right? I mean, before you go in, you say, I need 60 votes. And then the minute you say the word universal single payer, you can count up the 10 that you've lost. So you don't have to spend much time on it. You need 60. You're not going to have 60 if you say single payer. You're not going to have 40. So I don't think it was a matter of conscious ever not having that conversation. Somebody said it for sure on the House floor, but it didn't have any chance of succeeding. The closest anybody came was the public option, which we could talk about whether it was a meaningful thing or not. But in the end, they gave up the public option because they needed Joe Lieberman, and that was the end of it. I mean, it wasn't because somebody sat down and had a values and meaning and whatever discussion. They just said, we can't pass this thing without Ben Nelson and Joe Lieberman, and they're not going to sign on for a public option, and so that's over. And that's how politics works, and it's a good thing. I mean, it's a really good thing, because otherwise it would be the six of us at this table designing health reform, and you don't want to see that. Yeah.
I have two, if you only have time, the second one. The first, apropos the public option. A marketplace reporter called me the other day and wanted some comments on the failure of co-ops. And I said, that's not a story. They were set up to fail.
Right.
Very, very old story. So one question is, why'd you bother? And then the second, I think, deeper question.
So the answer to one is really easy. Kent Conrad.
Yeah.
He wanted co-ops. He needed his vote. They got co-ops.
When I
mean,
talk
that's how things work, right? That's how the world works.
Okay, there
Sorry,
goes
guys.
$2 billion because they were not set up to succeed. And then the second, and maybe that's just peanuts.
Well, no, it's not that. Look, so it was some money, and it was a dream, and there was a coalition of people who liked the idea. There is a coalition of people. There are a group of people out there, hard for us to understand them as economists, who believe that these add zero value to anything, right? And that the big problem in the healthcare system is the profits of insurance companies, and if we just got rid of the profits of insurance companies, we would be Canada. Okay? There are people who believe this. They're good people. They just don't think the same way as you and I do. And so they thought, if you say these things can't make profit and they're going to be consumer run, then it doesn't all the rest of it doesn't matter, because goodness and mercy will prevail.
So then that might be your answer to my second question, which is, how did legislation with so many economists involved include a profit cap, the minimum MLR?
So the minimum MLR, well, so actually this is a fun story, because this is one where I was wrong. So one of the very first arguments I got into when I got to Washington was about the MLR. And so nobody knows what the MLR is, right? So let me explain. One of the very, very popular provisions in the health reform law, very popular, publicly very popular, is that insurance companies can't make too much money. Right? So they can't make more than 15% profit on their large group business. They can't make more than 20% profit on their small group business. It's like that, right? So there are caps on how much profit insurance companies can make. And everybody loves these, because doesn't it sound good? I mean, we were just talking about caps on how much money pharmaceutical companies can make. This is a really attractive idea. So when I first got there, we had to figure out wasn't the MLR, we were doing rate review. So, because the MLR was baked into the law. And all the economists were like, you can't do rate review. It's going to be a disaster. You can't do this. And if you want to do rate review, make the number 15% or 20% or something that's non-binding. Don't do it. And it turned out, not only did we do it, but by all evidence it worked. It actually brought premiums down. The places that enforced rate review had lower premium increases. It doesn't seem to have done anything to the stability of the insurance industry. The MLR went into place, and the insurance companies made loads of money. You know, things don't work the way that we always think that they do. I mean, was it crazy? Well, the CBO said, actually, the CBO is really clear on the MLR. The CBO said, if you set the MLR above 85%, we will score the whole thing as on the federal budget. So the CBO basically said, we believe an 85% MLR is not going to be binding in any meaningful way. So you can go at 85%. And that's really what happened. So in many ways, I think what happened is that, except in the non-group crap market, the non-group garbage market, the MLRs were not binding. And the non-group garbage market had so many other things that were bad that actually it was okay to do it. That's the way I would read it. I mean, so it was, the economists did matter there, because they would probably have set the MLR at 90 or 95, right? Yeah.
How did the provision about not funding Medicare using quality adjusted life care, how did that get into the law?
Which one? Sorry.
You can't make any reimbursement decisions based upon analyses using qualities.
Oh, yeah. No, so that's an old one. Sorry. The question was, the law says in some way, not precisely, that Medicare can't, somebody here had asked about rationing, that Medicare can't make any coverage decisions in which it considers quality adjusted life years, which is the standard way that you would measure outcomes if you were concerned about allocating resources to the people who are likely to gain the most from it. So you may remember the death panels. Do you remember the death panels? So when the law was being debated, there was a truly innocuous provision that had been inserted in an earlier version of a Medicare piece of legislation by, I believe, a Republican legislator. It was as innocuous as they come, that said that Medicare would reimburse physicians for having conversations about end-of-life care with their patients. That was what the provision was. Sarah Palin found it, and she went to town on it and said, these are the death panels. This is going to be rationing. And so the Congress just basically fell over one another to make sure that there was nothing in the law that would suggest anything that might look like rationing. So, yeah. Yes.
Yes, there's a provision in the ACA that has directly benefited the Houston community that I want to tell you about and then ask your advice on how to keep it going. CMS was directed to have a demonstration project to fund graduate nursing education like we fund graduate medical education. And there were to be 5 places in the U.S. selected, and Houston was one of those places. And the intent was to produce more advanced practice nurses or nurse practitioners and to train them to be primary care providers and be out in the areas. This project is now in its 4th year and has been wildly successful. I think we've done about 4 times as much as we had originally said we could do. However, this is just a demonstration, and once it's over, we have no guarantee this will, it has to be reenacted. And the evaluation of it doesn't take place until 2017, so we know there'll be a lag, and we're going to lose momentum in the preceptors and people we've had in place. Is there any hope for us to get this as permanent legislation, or what's your advice?
I'm not in Washington anymore, so I personally can't do anything for you. I should just preface my remarks with that. And Congress doesn't seem to be passing a whole lot of legislation these days. So this would require, I think, a new appropriation, which is likely not to be forthcoming. Probably the only game that you could play is to see if you could get it into the figure out a way to put it into the Center for Medicare and Medicaid Innovation, the Innovation Center in CMS, which has the dual advantage of having some money that doesn't require an individual appropriation and having a provision that if the thing is shown to work and to save money for Medicare, which is a long shot, but then the Secretary can extend it to all of Medicare without going back to Congress. Now, I could not opine on whether that you're likely to achieve those goals, but that is probably what I would think to do. Yeah.
Yes, as is the case with enactment of any legislation, the lobbyists were all over the place, and I guess I'm wondering whether during that period, are there any examples of lobbyists that were working to get the bill to the legislation?
Oh, for sure.
Oh, no. And then turned around and just opposed it totally, even though they had gotten much of what they wanted, if not all.
Well, so I don't want to cast aspersions on any of my colleagues or friends, but let's say, so the America's health insurance plans, for example, the insurance lobby was very much in favor of passing the law, and then was, of course, an endless source of torment once the law was passed as the regulations got written, and in various ways wanted to block various things, which was totally predictable. I'm trying to think about the other main lobbyists. The unions were not as happy with the plan after it passed as they were before, but I don't think they ever really opposed it. I don't think anybody took the full swing 100%. The really interesting thing with healthcare reform, which goes back to the little pretty girl with cancer, is that of course, before the law passed, the one group that was completely not represented in lobbying were the uninsured themselves. So all the people who were lobbying for passage of this law were kind of coming at it from an angle. The actual people who were going to benefit were really never at the table, which is also kind of interesting. Yeah, Cedric.
So I've heard some, murmuring from like Paul Ryan about turning Medicare into some kind of, for lack of a better phrasing, voucherizing it a little bit. Is there?
Do you want that talk? That's the next one. That's like.
Yeah. Well, I was just wondering if with your time in D.C., had you heard anything about maybe like the next wave, like Obamacare 2.0 or 3.0 or whatever? Is there going to be anything for Medicare or Medicaid?
There is continuing interest in moving to a Medicare program that would insulate the federal budget from the rise in, from increases in costs, in the increases in cost of healthcare. And we could debate whether that's a good idea or not. My own view is that it's a terrible idea. I don't think the federal budget should be insulated from increases in the cost of healthcare. I think that would be a mistake. But that's a different, I mean, that's a different thing. Pragmatically, I think the challenge in voucherizing Medicare is that risk adjustment is a very imperfect business. The more we learn about it, the more ways it turns out that there are to manipulate it. And it's not so terrible when you're dealing with a population that is largely healthy, but once you're dealing with a population that has had an accumulation of illnesses, which is what happens with the elderly population, you're in very difficult water. So I think one problem is, I myself, even though I work in this field, I'm pretty dubious that we could really get the risk adjustment great. The other thing I think, and now I will disagree with several of the people at my table, I see no evidence at all that the private market has ever been successful in keeping prices of providers down to the levels that Medicare has been successful at doing. And I think there is a growing literature that suggests that it's actually Medicare prices that keep private prices lower, that in fact the private insurers are benefited when Medicare lowers its prices. I do not believe, with price transparency or otherwise, I have just never seen it, and so I don't believe in unicorns, that the market would actually keep prices down. I just don't see it. So, I mean, yes, it's true, it happens in many other sectors, but I have never seen it happen in medical care. We didn't see it in the 1920s, before we had widespread insurance. We still saw people, we didn't see it in the 1600s, when high-priced doctors were already being complained about. So, I'm just not persuaded that you can do it. And right now, a lot of the reason Medicare is not that expensive is because they're able to keep prices down. And shockingly, and no one understands this in the entire economics community, but there is almost universal agreement in the world, Medicare Advantage plans are able to pay hospitals and doctors lower prices for their Medicare Advantage population than for their commercially insured population, using the same hospitals and doctors from the same insurance plan, because Medicare prices are low. Shouldn't be the case. You'd think that a doctor or a hospital would say, you're Aetna, you pay X. But we know that Aetna pays X for its commercial population and X minus almost the full Medicare amount for its Medicare population. If that went away, you'd have to tell me a story that I would believe, and it'd be hard to persuade me that the whole market is going to come down. Does that make sense? Okay. All right. Thank you, everybody.
Thank you very much, Dr. Glieg. You know, it's always good to hear a presentation where you can learn something and laugh at the same time. But, you know, I really must say, whether you think the Affordable Care Act is a good thing or a bad thing, it is also really, we were lucky today that we did not hear something based on political rhetoric, but rather a description of why things happen in the legislation and sort of the background and why things played out that way. So we do have one more talk. We're going to take a 15-minute break before we hear Paul Howard. Also, on your tables, there is a paper survey form about the conference, and if you have time, please take the time now to fill that out and just leave it with someone at the front, because we do appreciate that feedback in terms of how we design our conferences in the future. So we'll see you back in 15 minutes.